The following podcast is brought to you by Kidney Stone Prevention Clinic of Orlando. Hello and welcome, everyone, to the Crystal Clear Kidneys podcast, powered to you by the Kidney Stone Prevention Kidney of Orlando, Florida. And I'd like to introduce the star of our show, Dr. Paul Dreyer, nephrologist extraordinaire. Dr.
Hey,
Paul, so good to see you.
Yes, great to see you again. Thanks for having us on.
And I always chime in, the doctor will see you now. That's my most favorite thing to say. And everybody, please hit like and subscribe to the Crystal Clear Kidneys channel on YouTube would be great. Because this show is not only about, preventing making kidney stones, but it's about general kidney health and general overall health. So which leads us into our exciting topic today. It's very contemporary, very topical. I mean, it's in Chicago, where I live, an operation was performed a couple of weeks ago on a kidney transplant patient, not using general anesthesia, which many believe is a game changer. So without ado, I'd like to introduce you to Cheryl Dreyer. It's not a coincidence that she shares the same last name as Paul. Cheryl, welcome to the show.
Thank you.
So
Thank you
good
for
to
having
see
me.
you.
Thank you.
Everyone, just to let you know, Cheryl is a certified registered nurse specializing in surgical anesthesiology, one of the tops. So she's our subject matter expert. She's extremely experienced in that. So we're so glad to have you, Cheryl.
Thank you.
And let's kick this ball off, right? So everybody wants to know, when you heard about this, Cheryl, what was your immediate thoughts on what transpired at Northwestern University Medicine?
Well, in the anesthesia community, it's very exciting. I think they've been doing this in Europe for a little bit, and it is a game changer. Anesthesia can have side effects that are detrimental. There are many people that will benefit from a quicker, quote, easier anesthesia.
And Dr. Paul, of course, someone that needs a kidney transplant, I'm guessing they're not in great shape when it comes time to do the transplant. Is that true?
Yeah, well, yes, having kidney failure certainly impacts their overall health. But the patients that are recipients, they've gone the transplant clinics have gone over that patient with a fine-tooth comb, and worked up their cardiac risk and screen for all malignancies and to make sure this is a healthy person. Yeah, in order to get the transplant, because it's quite a valuable commodity. And so they're tasked with, giving it to patients that appropriately should receive them. And if somebody has some illness, then they have to, like if I have a patient that has cancer, they have to wait a certain period of time and be deemed cancer free before then they can be eligible for the transplant, because the last thing I want to do is immunosuppress somebody that's got an active cancer. That can be very difficult. So
I guess, they're working against each other. Cheryl, so if someone, have you been involved where an operation had to take place regardless if they're not in the best shape or not?
Absolutely.
So what precautions do you take?
Well, let me just back up for a moment and tell you exactly what spinal anesthesia is.
Yes, let's do that.
So let's just start there. So a spinal anesthesia is a regional anesthesia, and it's placed between the lumbar vertebrae, and a numbing medication is injected into the spinal fluid. This causes you to become numb depending on the amount of volume that you use. A 6'6" patient would need more volume to get to a higher level of anesthesia than a 5-foot person would. So you would it's very quick. It's very easy. The patient sits on the side of the bed in the operative suite. You do a little cleaning on the back and inject this medication. The duration of a spinal is about 2 to 3 hours. So that is something to take into consideration, is the surgeon's skill, the availability of the organ. Is the organ in the building? Is the organ being flown in? That type of thing. So you want to time this very carefully.
You brought up a huge thing that I didn't think of. The time is only 2 to 3 hours.
Correct.
So that's huge as compared to an 8-hour, 10-hour surgery.
Correct. So at that point, if the surgeon has a little trouble or, something goes awry, as it often does in surgery, you would just need to go to sleep at that point.
Oh, okay. I thought it was a game changer for everything. No more general anesthesia.
Anytime you do a spinal anesthesia, you need to be prepared to convert that to a general anesthesia.
Oh, that's really good. Okay.
Yeah.
All right. So also in the article and the various articles, the patient states that he didn't feel anything and he felt great afterwards. But the thing was, he only stayed overnight and he went home. Is this typical of a spinal block patient compared to a general anesthesia patient? Is a quick turnaround time?
As far as anesthesia goes, we have patients that leave within a couple hours after their procedure. So say a hip patient, maybe a hip fracture, a hip replacement, those patients can go home and as soon as it wears off.
Obviously,
so keeping them all night from an anesthesia point of view is not necessary. Keeping them all night from a metabolic or a kidney point of view is necessary.
Well, yeah. So will the logistics there, now that I'm thinking about it, if the patient went home the next day, depending on how they prepared the patient's immune system, there's different medications. The most common one is called thymoglobulin, and it's made from rabbits, and it's against human lymphocytes. And so the patients need several days of that typically. And the first dose, they feel pretty crummy because the lymphocytes are all getting chewed up. And
for
so
those
they release
of those don't know what's a lymphocyte.
Lymphocyte is a type of white blood cell, and in particular, it's the ones that cause acute rejection in kidney transplants. So you have all this stuff that gets released in the bloodstream. So they get pre-medicated with Tylenol and steroids and Benadryl and that sort of stuff so that they can tolerate getting this medication. So that patient, unless he didn't get induction or he got something else, there's another medicine that's used called Similac, where you get it on day 0 and then you get the second dose on day 4. But typically the patients will get thymoglobulin. The reason we do that is because the medicine that we use for the anti-rejection long-term, which is typically tacrolimus, but it might be cyclosporin, is toxic to kidneys. So they don't want to dump a toxin on top of a fresh kidney. They want to make sure the kidney's working, and that's the benefit of giving thymoglobulin. So that's all dependent on how they did.
Could you tell us what's homoglobulin? Just for everybody's listening. Yeah.
So what thymoglobulin is?
Yeah. Just real quick.
It's a medication. Yeah. It's a medication, and it's harvested from rabbits, and they put in the rabbits human lymphocytes so they can create antibodies against our lymphocytes, and then they harvest this antibody against our lymphocytes from the rabbit and then inject it back into the patients. Yeah.
Amazing. Go ahead, Cheryl. What else can you add to that?
Oh, as far as being discharged home?
Sure.
Well,
yeah.
Okay. Well, let me back up. So I think the number one thing when considering a spinal anesthesia is patient cooperation and patient willingness to participate in this type of an anesthetic. The operating room is a very austere environment. There is, just to be quite frank with you, you smell burning flesh. You hear your blood being sucked up into suctions. There's banging, there's noises. In hip surgery, the patients are unable to tolerate that noise, and we still have to sedate them on top of the spinal. We use a medication called propofol, and they're essentially asleep, but not. There's a little bit of a fine line between general anesthesia and non-general anesthesia. So this patient would have to be very, very cooperative and very invested to just be able to tolerate this environment. And I have to say, I don't want to inject any bias into this conversation, but 100% of my patients all the time say, make sure I'm completely out. I do not want to be awake for any of this. So I think there probably is a little bit of a niche for this, but I don't see it being performed without some underlying sedation coming along with it.
You brought up another good point too, is can the patient tolerate the noise and the smells and the sounds? I mean, this is amazing value add that you're giving to this conversation that nobody talked about in any of the articles. This is fantastic.
And you feel pressure, and you feel, and another issue, I don't know if some of your listeners have had a C-section or their wives have had C-sections, but spinal anesthesia can cause a very low blood pressure, and they experience nausea and vomiting as a result of that. And it's on the article, listening to people talk about how wondrous this is, there are some problems with spinal anesthesia as well. So it would be a very careful patient selection process.
They didn't talk about that as well. So that's another value
Right.
add that you had. Wow. Amazing. Do you think, though, that, that this is going to become more and more prevalent in organ transplants as time goes on?
It just depends on where the organ transplantation is. So in order to block the field, there's a level where you need anesthesia and there's a level where you need to breathe. So say, for instance, a gallbladder would not be eligible. If you're having gallbladder surgery, you can't block that with a spinal because you're going to affect your diaphragm. You won't be able to breathe at that point. So because of where the kidney is situated in the pelvis, it's situated low. This will work for that. So it just really depends on the surgeon, his timing, the actual surgery, and then again, the patient. There are some contraindications to spinal anesthesia, and that would be a patient that has valvular problems in their heart, valves that are very narrow and they're unable to push the blood out very well. That's also a problem for general anesthesia. But if a patient has a bad heart, not a great candidate for spinal anesthesia. If a patient has any sort of a brain tumor or maybe a lesion in the back, you don't want to be penetrating the back to go through any sort of, say the patient might have shingles type of situation. You would not penetrate those lesions to give them a spinal anesthesia. So there's just so many variables that would go into this anesthesia plan.
Yeah, like the other problems are, MS, shingles, probably not, well, you won't rule you out, but not maybe the best candidate for it.
Correct.
As compared to the articles where they painted as sunshine, this is the most wonderful thing in the world. So,
again, don't want to insert my bias, but
what's your expertise?
If I can interject there, if a patient had significant heart valve problems or had active shingles or trying to remember what else you said, Cheryl, but
space occupying lesion.
Oh yeah, if they had like a brain tumor, I mean, that's all going to be deal breakers for getting a kidney transplant. So if they we've worked people up and we found stuff like that. You'll find heart disease commonly, or I remember having a patient and had prostate cancer, didn't know it, but they worked him up and they found it. So he had to get the prostate cancer treated first. So all those things that would preclude you from getting spinal anesthesia would also preclude you from getting a kidney transplant. So
there's a lot we don't know. I'm the general pop, you guys know, but I'm the GP. I guess that's the new lingo. So, but that's pretty amazing, Dr. Paul, to say that. Yeah, there's a lot that goes into it. Just, it isn't as easy as just having a transplant. Oh, I need a kidney transplant. Let's go.
Yeah, it's a lot of workup, leading up to that, and then making sure the patient's immune system is going to accommodate the transplant and not reject it. And then sometimes you have to prepare them that way if they've got active antibodies, because that gets checked every month in a patient that's on the wait list. So there's a lot going on. So in reading between the lines, when you read the article, I got two things to say about this. One is, I think this patient was relatively healthy and they elected to do this. It wasn't because he couldn't tolerate general anesthesia that they had to compromise and provide spinal anesthesia. It's because he was a good candidate for spinal anesthesia. And so that's why, and like you guys said, it's going to give him a speedier recovery. So that's the one thing. And the other thing I'd comment on about picking the right patient, that's valid, and making sure they can be awake during it. And if I remember right, I think the patient said that they showed him the kidney before they put it in. They're like, "Hey, this is going to go in you now. Here's your kidney." And
looks good.
So you can't freak out when that happens. You got to be cool with all that stuff. But it
sounds like this was a patient that was in good mental shape, physical shape.
Absolutely.
Yeah. Not young guy as well. And I guess the article said he's had kidney issues from a younger time in his life, though. So he's dealt with it for many years. Cheryl, what else did we miss? I hate to put you on the spot here, but did we miss anything else that, our listeners can get a value from this? beyond the national news of just kind of cursory go over, which they do on everything, we had a little bit of a deeper dive here. Anything else we should know, just for our general knowledge?
Well, I mean, just know that an anesthesiologist or a nurse anesthetist will be with you the entire time, regardless of the anesthesia that's chosen. And that would be a decision made as a team between the anesthesia provider, the patient, and the surgeon, talking about duration, talking about, is this patient have uncontrolled anxiety? Does this patient have a bleeding disorder? We would draw labs and make sure that they're clotting. They don't have any clotting disorders or anything like that. That would potentially be a problem when we insert that needle into the spine. But again, these patients need to be pretty cooperative, pretty invested. And it would just be a community decision. I'm not sure if they would be able to just schedule it as a spinal and not include the anesthesia provider in that decision. It would be something that maybe would have to be a preoperative meeting.
Yes, I would believe they all convened and came up with this plan.
Absolutely.
I don't have any doubt about that.
So the anesthesia provider in a typical anesthesia would just come out to the pre-op area, do a very in-depth interview, a history, physical examination, and then make that patient part of that decision. And if the patient is, this is a joyous time. It's wonderful to get a kidney. You've been hooked up to a dialysis machine for years, and this is a celebratory time. You may find a portion of the population that just is like, I'm digging it. I'm into this. Let me see. But I have to say, most of my patients do not want any part of knowing what's going on in there. So
yeah,
make sure I'm asleep.
But I think you're right. I mean, this is potentially going to become more commonplace. Yeah. And we all know when we were born, our dads were out in the waiting room, right? Handing out cigars. Yeah. But nowadays you got the husband right there going to cut the cord, So, yeah. So similarly, I think this might be something that becomes more commonplace and patients and families are going to be more accustomed to, and it's not going to be so, anxiety provoking as it becomes more and more the norm.
That's you guys have added so much, the thought of what's the mental state and it only lasts for 2 to 3 hours. That's something to consider. So it isn't just, you've got to consult with your team. And I think that's one of the nice things that everybody does. So that really sounds good. Okay. So did we miss anything else about this operation? Because Cheryl, just to let you know, Dr. Paul and I, when we wind up our podcast, we always go best practices, best liquids to consume, and best foods to avoid.
Look, let me do this since it's not a kidney stone podcast. Will, if the one closing remark I would have,
yes,
as a pitch is, and I think this statistic is correct, but I believe that there are 14 dialysis patients per day that pass away that are on the wait list to get a transplant. So I would encourage everybody, if at all possible, to be willing donor in the case of your unexpected, death. And the problem we have is you have to consent the families. And so in order to take it, so imagine your 18-year-old son was in a motorcycle accident and had a severe head injury and now is deemed to be brain dead. And then they come to you and they say, oh, can we take his kidneys for these? And so people are not in a condition to really think about it at that time. So it would be so nice if we had awareness to say it's tragic, but it's going to go to do something good. And you can make something good out of, potentially get some good out of such a tragic situation. And then I know they even they don't give names, but they'll allow correspondents to say, hey, I got my kidney transplant last year and it's doing great. I'm off dialysis. I feel terrific. So I just want to thank you for that donation. And that has been done for sure. And I think that reassures families later on that, hey, that was a good decision. It really made a big difference in this person's life. So just something to throw out there. Be conscientious if you can to be an organ donor.
Yeah, that's amazing, Dr. Paul. We in the news, they talk about physician burnouts and, medical staff burnout. But this is one of the rewarding features of the job is to help save lives, and to make a legacy out of a life too, so this is, pardon me, this is really good stuff. I know it's not. This isn't a kidney stone podcast. I always like repetition, folks. So let's go over anything else. Anything else that we need to before we do our usual hammer 'em home with best practices. You guys did an amazing job today too.
Yeah, we appreciate you moderating.
Anybody that's listening, though, please hit like and subscribe. You get, besides kidney information, you get general health information that you just don't get anywhere else. So this is really great information with two very experienced, top of the profession people here with us. Okay, so Cheryl, maybe you can help us too. Let's go through. Let's go through what liquids to avoid if one wants to keep optimum kidney health and not make stones. If you haven't, great. Let's keep it that way. If you've made one or two, let's avoid that. So best practices, Dr. Paul.
Yeah. So again, you want to get in 2.5 liters a day, preferably water. But if you're going to avoid certain beverages, it would be anything that has high fructose corn syrup as its sweetener and grapefruit juice. So the caveat there too is people that drink tea have less stones, but if you do have high oxalate, you might want to be conscientious about that. But coffee's okay, beer is okay. And so you should consume in moderation for other health reasons, but with respect to kidney stones, it won't put you at higher risk.
And of course, Cheryl, for you, the opposite is true, right? If I see you, I'm not supposed to drink water for at least 12 hours, right?
Yes. And please don't lie to your anesthesia provider. Please be extremely honest.
Just for everybody's information, what happens if you're a goofball and, you slugged a little bit of water, you're super thirsty or whatever, but they don't tell you because they just don't want to let you down. What happens if someone does do that?
So water itself is probably not fatal, but people sneak food, they sneak different, non-clear beverages. And what can happen is you can aspirate that into your lung and get a life-threatening pneumonia. You can end up in the ICU on a ventilator for a very long time.
That doesn't sound too good.
Please do not lie to your anesthesia provider, and be very upfront about any supplements you're taking, about however you're ingesting that. It affects the drugs that we give. It affects the amount that you need. And we're not here to judge you. We're just here to take the best care of you that we can. And we need all of that information.
Yes, that's really good advice. All right, Dr. Paul. And then we always say we ended on the solids, right? Stay away from the processed foods. The carnivore diet to an extreme is pretty rough on the kidneys. Is that true?
Yeah. Well, yeah. I mean, yes, because then you have a lot of nitrogen that you have to process and then eliminate from your body through your urine in the form of urea. But it also does put you at higher risk for stones if you have a heavy animal diet. So a plant-based diet is more beneficial from a kidney stone aspect. And then low salt. That's always, and again, like we've said before, there's other health benefits from that, but the higher salt the patients consume puts them at higher risk for getting stones. Okay.
This was a great podcast, guys, because I am a listener of this podcast and I don't know much what you guys know. So, I'm very grateful for this pairing that we've had. This is so much information. For those of you listening, again, this is the Crystal Clear Kidneys podcast powered by the Kidney Stone Prevention Clinic of Orlando, Florida, with Dr. Paul Dreyer. Dr. Paul, if somebody wants to get a hold of you, with questions about something, how do they do that?
Yeah, so go to our website, www.kspfla.com, and our phone number's on there. You can email us, different ways to contact us. So
hit the website, folks. And Cheryl Dreyer, if somebody's got a question they want to ask you, it's like, oh my God, it's like, what's the best way to contact you? I was thinking LinkedIn might be the best.
Sure. You can contact me through LinkedIn, or you can actually reach me through Paul's website as well.
Oh, great.
Yeah,
okay.
I'll pass the message along.
Or you pass it along.
Absolutely. Yeah. I'd be happy to speak
the better
to
half.
The Dryers, the power couple of Orlando.
Amen.
We love it. Yeah. So everybody, thanks for listening, and we'll see you next time. Thank you, Dr. Paul, for joining us. Once again, you can reach Dr. Paul with any questions at www.kspfla.com or at 239-221-1281, the Kidney Stone Prevention Clinic of Orlando. Until next time, folks.